Hi everyone. Today I'm going to do a presentation on quality assurance and auditing in clinical microbiology. So my name's Kristen Winterburn. I'm a senior biomedical scientist and a quality lead for Public Health Wales based in microbiology in Swansea. So I'll just go over some of the processes that we have in Wales, some of the things that we do um, in our local practice here. What is quality assurance? So it's a very broad process and it ensures that we have a suitable standard of service by monitoring all the aspects involved in it. In Public Health Wales, we're a network of most of the laboratories in Wales and we cover most of the services within microbiology in Wales as well. This includes quite a few reference units. So some of the reference units cover services in Wales and some are actually UK-based ones as well. So in Public Health Wales, we have key performance indicators, so we can monitor and feed back to the executive board to inform our performance and help shape our future targets. So these are set by the executive board and they encompass areas such as incident reporting, turnaround times, and external quality assurance. So quality assurance versus quality control. So quality assurance involves the overview of the whole process, whereas quality control links into the assurance and provides that assurance, but it's more immediate and ensures ongoing quality of the service following any implementation. So an example could be a reagent used to identify an organism. It needs to be verified, it needs to be compared to the standard and the reference method, and this is to ensure that it's fit for purpose. This would then be the quality assurance. It also requires suitable controls and regular monitoring. This would then be quality control. So why is it necessary? So we need to ensure that everything in the laboratory is fit for purpose and essentially does what it says on the tin. If it doesn't, if it doesn't, we could have problems that could implicate patient management further down the line. And we are required by our accreditation status to ensure we uphold the ISO 15189 standards. So this is the international standards for quality. And these are reviewed regularly by assessors. So in the UK, we have the United Kingdom Accreditation Service, also known as Ucas, and also extension to score for new developments. We need to monitor the changes that we implement, whether they work, what more could we do, what do we need to improve on, what do we need to change. And we also need to feed back to our users of what can be done by them to ensure that all of us get the very best service provided to each and every patient and we all work together for the shared goal. So what's included in quality assurance? So we have internal quality control. So we set up controls as per manufacturer's guidelines for testing different reagents work. So such as oxidase for Pseudomonas species, staph latex to indicate if you've got a Staph aureus or a coagulase negative staph. Internal quality assurance, so we'll assess the whole process from start to finish to ensure all processes have been performed as per our standard operating procedures, also known as SOPs. We undertake audits, so we do full vertical audits in selected areas as part of a network schedule, and supplementary audits such as transportation, urgent sample suitability, which we can then feed back to our users. And we also undertake external quality assurance. So we use Ucas accredited providers. We enroll onto multiple schemes to cover our services, which get scored and compared against all other users who are also registered to these schemes. But we also do a cross-site comparability studies within Public Health Wales as well, so we can share best practice. Quality management system. So we've recently moved over to this new quality management system provided by iPassport. It's an electronic-based system, and it's essentially where we have all of our procedures, policies, we have our health and safety documentation, we have templates for audits, IQA, any like downtime or error logs, anything like that. We have a set process that all of us in Public Health Wales abide by to make sure that we're all providing the same information. And this is really good for identifying any trends and everything as well. And we have all Wales SOPs. which we then can create smaller benches that are taking the information in the SOPs, but making it fit for purpose for our site. So we may have some small things in our site that are not included in the All Wales SOP because it doesn't affect any of the other labs, but we can then create our own control documentation and update that as per when the SOPs are reviewed. So it's a really good way of us monitoring to make sure that everything is up to date. All the controlled copies are available here, so all the staff are using the up-to-date information and they're following the current guidelines. Validation versus verification I'll touch on next. So validation ensures the product service does what it says on the tin. It's used to critique and evaluate it could be equipment, it could be a product, and it allows decisions to be made regarding the use of a process. So it may be good for one particular process, but not another. And it ensures a full evaluation of all aspects involved. So you're looking at workflow and where does it fit in with turnaround times? Where does it fit in with, whole laboratory work? And it also provides confidence in a process to allow for ongoing monitoring and review, knowing the full picture when you've done a full evaluation of the product. Whereas verification ensures the process or product is fit for purpose you want to use it for. So it might do, it might be a particular molecular test that, it picks up this particular resistance mechanism, but where does it fit in with one specific laboratory? So it ensures that it fits into the workflow in your lab. So it's pointless you having a test that does this, but then you get no samples to test it for. So you need to kind of verify it in that way as well. So it tests specifications and requirements and any changes that have been made. And verification is ongoing. So you normally do like an annual verification, particularly for any steps of uncertainty of measurement or anything like that. And it also allows you to ensure any changes to the kit are covered in the SOP. So maybe if a new target is included in a test now, you need to also now verify the new target when you re-verify. So it allows just like a constant ongoing process. And again, it's undertaken regularly to ensure the processes are done and the following guidance and is still current as well. So post-intervention verification. So this is something that we do in Public Health Wales for any intervention that we've had for any equipment. So if any equipment is down, if anything is serviced, if anything is repaired, we will do post-intervention verification. So we have a set spreadsheet for all of the different equipments that we have. Obviously, this is just based on the single-ton ones that we have in Swansea. And we ensure all the controls have passed, the errors have resolved, and the instrument's actually working as they should be. We'll test the electronic links to our LIMS, so our Laboratory Information Management System, and also that this information is transported to WCP. So WCP is the Welsh Clinical Portal, and this is the area where clinicians and other healthcare professionals can pull results for their patients. So we don't tend to do paper reporting, it's mostly electronic now, and this is where they can get this information, and they can also put clinic letters, X-ray reports, different scan reports, everything can just be stored in one patient record on Welsh Clinical Portal. So it's quite a handy piece of technology there. And we also DateX. So DateX is our form of incident reporting. So if we had a particular bay on a particular molecular instrument that kept breaking all of the time, and every time it broke, we raised a DateX incident report against that. When we do a DateX report for a month, 2 months, 6 months, we can actually see how many times this has happened, and we can identify if there's any trends. And by doing this, it allows us to do a full DateX report for all of Public Health Wales. So everyone that has the same instrument may be having the same problems. And then this could be something that we can contact the manufacturer and discuss, why, what can we do to stop it from happening, or maybe get reimbursed for the task that we've lost. So it's a really good way to monitor the trends in this area. And we also log engineer reports, any service reports, what we need to do, what's been done. And again, all of this links in to allow for trend monitoring. So if we can see we're getting consistent problems in one site, we can then pull the DataX reports and we can then contact the Public Health Wales quality team and discuss it with them. So it all kind of links in together, but ensures the problem's resolved and we're now back up and running as we should be. Ucas assessment and ISO. So ISO 15189, these are the international standards for medical laboratories. So we all need to work towards these standards in order to maintain our accreditation. And ISO 15189 accreditation ensures confidence in the quality through a process that verifies the integrity, the impartiality, and the competence of staff undertaking the testing. Assessments in the UK are done by Ucas, and accreditation will ensure the labs meet the requirements, including the operation of a quality management system and the ability to demonstrate that activities are performed within the criteria set out in the relevant standards. Ucas assessment, what do they look at? So they look at verifications. Are they undertaken regularly for processes? Uncertainty of measurement, is this done regularly for subjective areas? So AST reading, antimicrobial susceptibility testing, we do uncertainty of measurement every time we use Ucas, EUCAST, the European Union standards for AST in the UK. And every time we implement a new version, because they're reviewed annually, we do uncertainty of measurement before we go live in all of the sites. So we write up the uncertainty of measurement, and this is signed off by, for Swansea, signed off by myself, the operations manager and the clinical lead as well, to ensure that the uncertainty is low, the uncertainty of measurement is low, so and works out the risk of that on patient samples. So we need to undertake these regularly for all subjective areas. Another area could be things like doing cell counts and parasitology measurements as well. Training and competency documents for staff undertaking the task, so they'll regularly look at these. They'll look at the equipment. Is it maintained? Do we have downtime records? Do we have service records? And do we have service contracts in place? Are SOPs available? Can staff access them? And any printed copies that we have, are they controlled copies? And are they the most current ones that are available? Audits, I'll look at those. They'll look at the internal quality control, the internal quality assurance, and the external quality assurance. And EQA in particular, they'll look at scores. How have you performed in certain tests? If any that you've dropped points on and you've done maybe not so well, have you got any investigations you can show them? Have you got any improvement actions? And what have you learnt and what have you done about it? The user survey and user feedback, so they'll look to make sure, do you have communication with your service users? What have you done with any user feedback that you've had? Have you taken it on board? And again, this links into the next point for user engagement as well. Is the pathology handbook up to date and demonstrates the sample type, the volume, and the turnaround times? So in Swansea, we have the pathology user portal. It's essentially like Google for pathology tests. So you type in whatever you want, like a keyword. So if you were looking for urine microscopy, for example, you can type in the word urine. The test will come up. It'll tell you the minimal sample type you need. If you can't transport it to the lab, how you store it, what the turnaround time is, whether it's a test done in-house, whether it's a test that needs to be referred away, any particular sample requirements we need. So for us in Swansea, we need the containers with the boric acid in them, and anything that doesn't have boric acid in them will be rejected and they won't be tested. So that is listed on the pathology portal. So our users can freely access that, and then anything that's not on there, they can contact us. Some of the specialist tests has a comment on there to say they need to contact us for more information, so we can discuss with them then if they need anything. Ucas non-accredited tests. So this is what's advertised on our website. Public Health Wales has been awarded Ucas accreditation for compliance with ISO 15189/2012, but the following tests are currently outside our scope of accreditation and awaiting assessment by Ucas. So a lot of these did get assessed when we had our last visit in February. So we're clearing the findings at the moment that we had for these to be able to get them on our scope of accreditation. So some of the things included in this are the Sysmex urine microscopy, the SARS-CoV-2 testing, because we had to implement a lot of those pretty sharpish due to the pandemic, and we've got multiple different ones around the network. Rapid respiratory detection using BioFire, and I think they're the ones I know for bacteriology that we've done. The other ones are going to be assessed in the next assessment, but we've got lots of new things coming in. So we'll likely have a lot more things being added to this list when they're live to then get assessed by Ucas in the next visit. So Ucas assessment, so they'll usually assess certain areas, so they may look into the areas that had findings last time or had any improvement actions that they suggested. They'll look at processes and evidence to support a quality assured service. They'll speak to staff and discuss processes. They may discuss areas for improvement and what they've seen elsewhere and can make some recommendations. Findings are provided in a formal way, the standards stated with the agreed actions that have been discussed with the quality manager. So these may be mandatory findings or recommendations. And as we're a network in Public Health Wales, we need to take into account all of the findings for every site. So it might be a finding that's in one other lab that's not in ours, but we need to look at do we have the same problem? And what's the impact of this on our individual labs so we can feed back because we all work in to the same standards. So Ucas findings and extension to scope. So findings are usually given about 3 months to complete evidence and submit it. These are then assessed and decide whether this fulfills the agreed actions. It's documented the person who is tasked to, the root cause, the underlying reason, how has this been reached, the extent, who and what is affected, and on what scale, the impact, the significance of the non-conformity, the action taken, the evidence submitted, and then for extension to scope, assessors will look at all areas covered to ensure you're already working to the standards and whether or not they will add it to the scope of accreditation. So microbiology and audits in Wales. So vertical audits are undertaken in the network as per a rolling schedule. These audits are undertaken for all sites within the network. So for example, all bacteriology labs will undertake the same audits. So it ensures consistency in the network and sharing of information and best practice where needed. So all areas are covered with vertical audits and from start to finish of one particular sample. So it could be so one of the ones we've got listed here, CSF sample, for August to November. So a CSF sample will look at the request, do we have all the patient information? Do we have clinical information? Is the request stated on there? Is it dated? Is the time taken all available on there? You'll look at receipt in the lab. Have we documented the date and time we received it? The pre-processing, the processing, is it within turnaround times? Was it a delay in processing? And if it was, why? It includes all the processing side, includes all consumables, all equipment, staff competency records, so it can be quite a broad process. And it'll also look at the reporting side as well. So I've popped in our 2021-22 schedule here. So the green ones are completed and signed off, and the yellow ones are in progress being reviewed. So the respiratory one was one of the ones I did just a couple of weeks ago. So it's a little bit overdue. So audit findings, Public Health Wales, and supplementary audits. So audit findings are detailed in the template and include what the finding is, what the root cause is, what's the immediate action, what's the corrective action, and an effectiveness check. So have the changes you've put in made a difference, or do we need to re-audit, or do we need to try something else? And the template I've popped in here, these are our supplementary audits that we do every year. So referred sample audit, urgent sample audit, specimen transport, and sample volume suitability. These are ones that we do annually. The electronic links are something that the IT department does for us to check the links for all of Public Health Wales. And the request processing and reporting stuff audit is covered by our IQA that we do every week in bacteriology. And then the extra ones are supplementary audits that I've put in place following findings from vertical audits. So Ucas comments for antibiotics when we've reported them, and media recording compliance was put in place from another audit that we had a finding for where we didn't record the media. So trying to think of ways that we can address them and monitor it when we need to. So everyday quality, this is just some examples I put in for IQC. So this is for our oxidase reagent for Pseudomonas aeruginosa and E. coli. So we have positive and negative control, and the staff document whether it is passed or failed. And there is a column that they'll sign next to it, but I've removed that for confidentiality purposes. So the dates need to be recorded, the lot number, and what section in the lab is being used on for traceability. So the control organisms listed, these are as per the manufacturer guidelines with the expected result. Staff then note whether they pass or fail and sign to take accountability for these tests per day. And all IQC failures need to be documented in a standard format that we use across Public Health Wales, an IQC failure log, and escalated to a senior manager. We then need to look at why, how many times has it happened, what impact it's had on patient samples, do we have an alternative to test them, and how many patient samples have been affected? Is it an ongoing failure? Does it need to be data taxed so the rest of the network can be notified? It could be, the lot number, anything like that. We can contact the manufacturer. We've got all the information then to send them. So it's just a good way that we can monitor these. Quality in AST is usually quite a big one. So as everyone's probably aware, AST is a massive area, very subjective, and there's lots of things involved in AST testing and a lot of monitoring and performance. So it's a big area for quality. So for us in Swansea and in Public Health Wales, these are some of the Ucas strains for detection of specific resistance mechanisms that we use in Public Health Wales that we test weekly. So we have everyone has calibrated rulers. These are recalibrated by myself annually. AST IQCs, we have control organisms that we test 4 times a week. So we do this for all our discs, all our e-tests. So this is to monitor quality performance of the media, the antibiotics, and the QC organisms. And this is fed back to the Public Health Wales network quality meetings by myself in my report. It's also I also use this data to inform the All Wales, which is Public Health Wales and non-Public Health Wales labs. So we have a group that we discuss any AST related issues, any media related issues. If we have certain antibiotics organisms that are trending too high, too low, or we keep getting repeated discrepancies, we can discuss it as as all of Wales and decide what to do then. So I take this data to these meetings. Example here is a combination of Mulhinton F and cotrimoxazole for strep pneumoniae. So we had issues with that a few years ago, and we looked at alternative media and we did a cross comparison between different media, different antibiotic suppliers, different QC organisms to see if we could find any kind of root cause for that. But that's now been resolved because I think the media formulation methodology was amended. So it's now resolved and we're back to using this drug bug combo. But it's really handy for us to be able to feedback in these meetings because we can see, is it just one site that's doing something? Has anyone else had the same problem and can recommend certain areas of improvement for us? Or is it a national problem that we need to look to discuss with the manufacturers? So this is our IQA example. So most of our IQAs in bacteriology are done by audit style. So they're not repeat tested IQAs. So this is the format. This is the standard form that we fill in. We're on a schedule which we follow with the rest of Public Health Wales, and we look at different benches every week. So this is the blood culture one, for example. So we have the lab number. Are the correct demographics from on the lab information management system? Do these match what on the request form? Is it the correct patients? Everything available on there? The test is being requested. Is it correct? And then all the plates in the media that's been used. Any microscopies, are they correct? Is it everything being transcribed correctly? Is it being read by? Who is it being read by? And different things like that. So we can look at the whole process and then look at the culture side on the next page. So it ensures samples are processed according to the SOPs, and the traceability for all processes, staff processing, reading and reviewing. Are the reports correct and consistent with notes made from the staff? Have all target organisms been worked up and reported accordingly? And is the final report available on the Welsh Clinical Portal? And does it show all the required information as it should? So does it have the organism? Does it have antibiotics reported? Does it have the patient information available? Does it have what laboratory it was tested in? So we'll check this whole process every week as well. EQA schemes. So we mostly do NACRAS for a lot of our schemes. So this one is for AST. So this is an example that I put in to discuss with the staff. So Swansea at the moment are performing well, which is just shown in this table here. So 0 is here, so we're slightly down here, but as between above or minus 1.96 is acceptable. Anything outside of these parameters is classed as poor performance. So we're fine. We're not in near those, so we're okay. I think this one was one of the examples I wanted to put in for Moxiclav. Yeah, so it was one of these ones that we had the correct result, but the majority of people in the UK, well, I think it's globally NACRAS subscriptions are. So the majority of people, if less than 80% of people get the result incorrectly, it doesn't get scored. So nobody drops any points. But for this one now, cotrimoxazole was supposed to be reported resistant, but only 53.6% of participants actually called us resistant. So we did actually call it resistant, but we didn't lose any points, but we didn't gain anything either. So it's really handy that we can kind of see and we can monitor our performance in this way. And sometimes we get some really tricky ones, some really interesting combinations that really make you think about it. But it's it is a little bit of a win when you get them correct, but it's also a bit disappointing then when you don't get the points for your efforts. So it's just the way that goes, unfortunately. This is another example for AST. So this was for Pseudomonas. So this was a picture I took of one of the plates. You can see we've got some really fuzzy little edge here, double zone for your meropenem and double zone for your ciprofloxacin. So for these two in particular, because they're bactericidal drugs, and TAS, you've got a bit of edge in here as well. We would read these right where the full inhibition is on the antibiotic, and we did in this case, and we did actually get them all correct. But again, it comes down to ceftazidime. We had this one down as I, which is not on this plate. I it's not intermediate, it's susceptible increased exposure, but we weren't scored on this. We also we didn't examine these ones, but we also weren't scored on piperacillin tazobactam as well, which would be this one. So we called this one I, which is susceptible increased exposure, but again we weren't scored on this one either. But for ceftazidime, in this instance, we've got all and UK subscriptions, different AST guidelines that people are using, and what the percentage of concordance had. So I think it was supposed to be for ceftazidime is supposed to be I. So 272 participants had that correct. 3 for CLSI had that correct. But it's still a 55% concordance. So it's still under 80%, and that's why they didn't score it. So it's interesting to kind of see these and see where we were compared to the majority. So yeah, it's quite interesting. Monitoring trends. So this is for antibiotics in Swansea. So we log all of our antibiotic data every day. Every day we test it, and then we review anything out of range. And then I normally do a monthly report for our trend analysis meeting in Swansea and comment on some of the issues that we're seeing. So if we have any reduced zone sizes for particular bugs, any issues that we have, so it could be like manual addition of any discs, it could be like a human error, what we need to do, and any action performed from that. If the wrong, in this case, the wrong QC organism was used. So it's a really good opportunity for us to look at weekly to determine if there's anything that we need to put in place immediately to resolve any problems that we have. So this is an example of some of the data that we have. So as you can see, this is our fully sensitive Enterococcus faecalis isolate. So for vancomycin, it's trending quite nicely towards the target line here, whereas for teicoplanin, it's trending more towards the lower end of the spectrum. And then again, when you look at this is it's a Van B VRE Enterococcus. Again, this is still trending quite low. We have got a couple on target and one above, but the majority of them are either sitting right on the end range here or slightly higher. But again, we've identified a problem with nationally for this. So we've put in place another mechanism for testing if we get a Van sensitive teicoplanin resistant patient isolate to test them by e-test. And if the MIC for teicoplanin is still resistant, which it probably won't be the majority of cases, we'll send them to the specialist antimicrobial chemotherapy unit based in Cardiff. So that's our local antibiotic reference unit, and then they can collate them and they can they're looking at the supply of antibiotics anyway, and they'll do studies into kind of different manufacturers and things like that. So they can use the data that we all send them to help with this. So regular reviews. So I collate a monthly quality report. I currently have 39 areas to review for internal quality control alone. So it's quite a massive report and takes quite a bit of time. Areas I cover in these are audit, IQA, IQC, EQA, any turnaround times, and any governance issues as well. So this is an example of one I did October 2021. So I'll collate, this is the IQC one, sorry. We've got the different areas, how often we monitor it, if is it satisfactory, yes or no. If it wasn't, what issues or trends have we identified? We need the root cause, the corrective action, review of effectiveness, reviewed by who and the date. So these are things I monitor every month, and then I'll put each one in attached to my quality report, and I'll put any comments on here that we need to do. And then this is sent to the network quality team for review, and everything is collated side by side with all the other labs in Public Health Wales as well, so we can do a full review. So we have quite a large meeting every month. So every representative from each site, the quality leads, will attend these meetings, and we'll go over all of the inconsistencies. We'll discuss anything we need to implement as a network, any lessons we can learn from each other, and different things like that. So these are all covered in this. Quality improvement projects. So a nice little one for this is blood cultures. So at the moment, Swansea Microbiology Lab covers 3 main acute hospital sites. So we've got the Princess of Wales Hospital, Marston Hospital, and Singleton Hospital. So Marston Hospital are our biggest service user. So they're one of the tertiary care units in Wales. So we've got a massive emergency department. There's a really large renal unit. There's the Wales Centre for Burns units there as well. A lot of surgical specialties are based there as well. So we get quite a lot of samples from Morriston, but we as microbiology are actually based in Singleton, which is the smaller of the sites. And obviously there's transportation and things involved in that, which is not ideal for patients. So due to the pandemic, we have implemented hot labs to do the COVID testing in more sites, so we don't currently have a microbiology presence. So we've opened 6, I think, around Wales. So in Singleton, we assessed the blood culture volume fill over a 12-month period and published the findings in the bulletin for the pathology users. So following this, task and finish groups in each site looked at areas of improvement and the data was generated again. And transportation is reviewed in our annual supplementary audits anyway. And it was last done end of 2021. And alongside this, we also did a blood culture processing audit, and transportation was linked again to all outliers in the processing audit. And transportation audit, we also had quite a lot of outliers that didn't come to us in the set time period as well. So there's quite a lot of delays that are linked to transportation. So in 2022 we opened hot labs, and we do have one now in Princess of Wales in Morriston. So as a new quality improvement project, all of the hot labs are now going to be processing positive blood cultures. So it's a really good opportunity for us now. We can repeat our audit. We can repeat the blood culture processing audit in all of the sites. And we can, what I'm hoping and I believe we can probably show the impact that this will have to patients, a positive impact of having each site processing these positive blood cultures, because it's going to improve better care for our patients and allow for cross-site comparability. But it'll also show that these samples will be transported to the lab quicker. They'll therefore then be able to be incubated quicker, and any positive blood cultures that we have will likely get them quicker as well. So all of these things can be addressed by repeating these audits, and it's quite a nice little quality improvement project that has quite a good clinical outcome as well for all sites. So it'll be quite a nice thing. We haven't gone live yet with the blood cultures, so this is going to be in the next few months. So it's going to be a busy time, but I think it'll be a really good project to get behind and see what data we generate. So that's kind of where we are at the moment. And I think that's it from me. So thank you for listening. Yeah, thank you.